Hello and welcome to the PTCB Prep Guide. This is your trusted source for clear, simple, and exam-ready pharmacy knowledge. Today, we're tackling high-yield respiratory medications. We're going to cover the big ones, brand and generic, break down the core concepts you absolutely have to know, and I'll even give you some simple memory tricks to make it all stick. Let's get right into it. All right, so here's our game plan. We're going to start with those emergency rescue inhalers, the ones for an active attack. Then we'll move into the daily steroid inhalers used for prevention. From there, we'll level up to combination inhalers, touch on some specialist drugs for COPD, and wrap it all up with common allergy sprays and oral steroids.
First up, Section 1, the rescuers. Think of these as the firefighters of the pharmacy world. When a patient is having an asthma attack and can't breathe, these are the drugs they need for immediate relief. For the PTCB, you absolutely have to know these cold.
Okay, so take a look at this. You see a pattern here? Check out those first two generic names, albuterol and levobuterol. They both end in terol. That is a massive clue for the exam that tells you they're in the same drug class. Primatene Mist, on the other hand, is kind of the odd one out. It's over the counter and uses a totally different ingredient. So, albuterol. The key takeaway is its class. It's a short-acting beta agonist, or SABA. Its one job is to open up the airways, and fast. But because it revs up the body, you can expect side effects like a fast heart rate, which is called tachycardia, and maybe some shakiness or tremor. The mnemonic is super simple and effective. When you can't breathe, albuterol makes you feel all better. So you might be wondering, if albuterol works, why do we even have levobuterol? Well, it all comes down to the side effects. Levobuterol is like a more refined, cleaner version of albuterol. It's more selective, so it often causes less of that racing heart and shakiness. The memory trick is literally built into the name. Levobuterol has less side effects. Easy, right? Okay, so we've covered the rescuers. But really, the whole goal of modern asthma treatment is to prevent the attacks from ever happening. And that's where our daily preventer medications come into play, starting with the foundation, inhaled corticosteroids, or ICS. And bam, here we go with another pattern. Look at those generic names, fluticasone and budesonide. You see the suffixes, sone and nide? Anytime you see those endings on the PTCB, your brain should immediately scream steroid. These are probably the two most common inhaled steroids you'll ever dispense. So unlike the rescuers that just open the airways, these steroids get to the root of the problem, inflammation. They calm everything down over time. It is so important to remember that these are for daily prevention. They are not for rescue. And the number one most high-yield counseling point for a technician? You have to tell the patient to rinse their mouth out with water after they use it. This prevents a nasty fungal infection called oral thrush. So let's imagine a patient is using their daily steroid inhaler. They're taking it every day like they're supposed to, but they're still having symptoms. What's the next step? What does the doctor do when one medication just isn't cutting it? Well, the answer is to bring in the heavy hitters, combination maintenance inhalers. This is a big step up in therapy. We're essentially combining two different long-acting drugs into one single inhaler to get maximum preventative power. Let's break this down. Each one of these has an inhaled corticosteroid, and you can see our old friends fluticasone and budesonide are back. But they're paired with a new type of drug called a LABA, which stands for long-acting beta agonist. This LABA gives a steady 12-hour bronchodilation effect, keeping those airways open all day long. So the big idea here is that this dual-action therapy is attacking the problem from two angles. You've got the steroid, reducing inflammation, and the LABA keeping the airways physically relaxed and open. And since these still have a steroid in them, what's our key counseling point? You got it. Rinse your mouth after you use it to prevent thrush. All right, let's shift gears a bit. Now we're going to move into some more specialized drugs. We'll look at a couple that are mainly for COPD, which is chronic obstructive pulmonary disease, and we'll also cover a really common non-steroid pill used for asthma. So this slide introduces a whole new class for us called anticholinergics. We've got Spiriva, which is a LAMA, and Atrovent, a SAMA. We'll compare those two in just a second. And then we have Singulair. See that leucast ending? That's your clue. It works in a totally different way by blocking these inflammatory things called leukotrienes. Okay, this is a classic exam question, so listen up. What's the difference between Atrovent and Spiriva? Atrovent is short-acting, or a SAMA, and it's used for acute COPD flare-ups. A great way to remember it is ipratropium, I pray to breathe. Spiriva, on the other hand, is long-acting, a LAMA, for daily maintenance. Just think Spiriva for respiration. The one big thing they have in common, the classic anticholinergic side effect, dry mouth. Now for Singulair or Montelukast. This is a super popular drug, mainly because it's a simple once-a-day pill instead of an inhaler, and it works for both asthma and allergies. The mechanism is right in the name, which is super helpful. Montelukast blocks leukotrienes. But with this drug, there is a massive safety warning you have to know. This is a black box warning. That's the FDA's most serious type of warning. And you can bet this is a high-yield safety fact for the PTCB. Montelukast has been linked to an increased risk of serious mental health side effects, things like depression and even suicidal thoughts. You have to remember this connection. It's that important. We are in the home stretch now. Let's round out our list with a final group of high-yield medications. This includes some very common over-the-counter nasal sprays and the powerhouse oral steroid that's used for severe emergencies. And would you look at that? We see our old friend, the steroid suffix SON, popping up again in Flonase and Nasonex. These are basically nasal versions of the steroids we've already talked about, used for allergic rhinitis, seasonal allergies. Then we have prednisone, the oral tablet, which is reserved for when things get really serious. So what's the key difference here? It's all about local versus systemic. The nasal sprays act locally, right there in the nose. So their main side effect is also local, like a nosebleed. Oral prednisone, however, is a powerful systemic steroid. That means it affects the entire body. It's used for severe flare-ups, and its side effects are way more significant, like insomnia, irritability, and even high blood sugar. Okay, you ready? Let's lock all this stuff in with a quick mnemonic lightning round. Albuterol, all better. Levobuterol, LEVA means less side effects. Fluticasone, Flovent improves airflow. Singulair, Lukast blocks leukotrienes. Aprotropium, I pray to breathe. Spiriva, Spiriva for respiration. And finally, prednisone, P is for powerful. Got it? And just like that, you made it through. This was a really medication-heavy lesson, so great job sticking with it. Every single minute you spend learning these drug names is bringing you that much closer to walking in and passing the PTCB with total confidence. Before you go, here's what to do next to make sure all this information sticks. 1. Review these drug names again later today. 2. Don't be afraid to rewatch any parts that felt a little tricky. And 3. Keep practicing those brand and generic pairs every single day. If this lesson helped you out, please do me a favor and like, subscribe, and share it with someone else who might need it. We put out more simple, high-yield PTCB explainers every day. Stay focused. You are building some serious momentum. I'll see you in the next one.